registered on the platform will make your lives a little bit easier, and I'm probably going to repeat a lot of the things you already know. But for those of you who haven't yet registered, in your browser, just type in detectedx.com. You go to login. If you have never registered before, you have to click register. If you're logging in after already registering, you just put in your email and your password that you would have created when you registered. But I'll just show you how to register from scratch. This is a form that comes up. I've actually pre-populated it. Please note that when you put in a password, you must be at least 6 characters long and contain at least one number and a mixture of uppercase, lowercase, and symbols. You click, I have an enterprise code, I've read the terms and conditions, and you register for the platform. You then put in the enterprise code that would have been provided to you, and you click submit. You'll then come to the DetectedX homepage, where we have a number of different types of modules available. You have been given enterprise access. It will come up straight away into the GE Healthcare DBT module with 10 cases. To open up the module, you just click and you say start, and the cases will load. So the viewing platform is like a universal viewer. It has all the feature functionality that you need to manipulate the images. You can change your window width and window levels using your left mouse click. You can tab through the hanging protocols using either your spacebar on your mouse, on your keyboard, or you can click on the hanging protocols here and move to the next hanging protocol. When you get to your DBT case, you will see that the image is loading. Just wait for it to load before you do any manipulation. You can then go through the slices by just dragging on the little blue scroll wheel on the right-hand side of the image, or alternatively, you can use the trackball on your mouse just to scroll through the images. On the left here, we have what we call the series, which is the thumbnails of all the images available to you for this particular case. And you can drag and drop from that left series bar into the image display window that you would like the image to be shown. If you want to go back to where you were before, you just click reset and it will take you straight back. You can synchronize the images, meaning what you do to one will happen to all of them by clicking the sync button over here. So if I wanted to, I could I click turn on sync, and then if I magnify, it will happen to all. And if I want to scroll through the images, I can do that using that button over there. Alternatively, you can right click and all the functionality is there as well. Or if you want, you can use the shortcut keys on your keyboard, which are listed over there, just to make it a little bit easier for you. You can also change the way the images are displayed on the screen. If you double click on an image, will open up just that single image and click again to go back. Over here, it will show you how many cases you've got within this module. And in this particular module for GE DBT images, we've got 10 cases. Professor Rickard will go through the cases in detail, but over here, if you get case information, it will tell you that this is a screening case. If it was a symptomatic case, it would tell you about the woman's symptoms and why she had gone to see someone. When you go through the images and you see something that you consider abnormal, you can mark the image, and then we have the bar rate classification, and you can put in your confidence level, put information about what you think you're seeing, and then save. If you think the case is normal and there's nothing to actually mark, there's nothing that you consider suspicious, you just go to next on your keyboard without marking any suspicious area. So then you just go to the next case, or you can click over here and open up the next case like that. Once you've done all the cases and you've marked all of the cases within the module, you can then, sorry, just taking a little bit of time to load the home computer. And once you've marked all your cases, you feel everything is normal, you can just submit. You just got to fill out a questionnaire, giving a little bit of information about yourself. And then you go next. And then you'll come up to your result page where it tells you what your positivity rate, your specificity, your sensitivity. You can actually look at the definitions of what they all mean, just as a reminder. You can also see how you score compared to other people. Obviously, I should not be a radiologist. You can download your score. You can send it via email to yourself. You can get a certificate of completion. But the most important part is that you can actually then go and review your answers, where it will tell you what you have marked, which is the yellow circle, and what is actually the truth, which is in red. And if you hover over those little circles, it will tell you information about the lesion and the truth of this case. And up here as well, it will tell you it's an abnormal case, and I had marked it, but I marked it incorrectly. And then you just go through the module by going next, and it will give you all the answers. So thank you. If you've got any questions, I'm sure we can answer them at the end of the session. Thank you.
Should I now introduce myself? So it's Mary Rickard here, and it's a great pleasure to be with you all this evening, and I'm hoping you'll enjoy this session. We're just going to have a short presentation now about DBT in clinical practice, and then we're going to do some case material. So I'll share my screen with you. So, has my screen come up?
Yes.
Good. Okay, so the plan is to go over a number of different aspects of DBT, or digital breast tomosynthesis, and the learning objectives are to recognise the limitations of mammography and understand the principles of digital breast tomosynthesis, and then to be able to compare the benefits and limitations. So we'll go through why we're doing it, and then what are the limitations of what we're doing. So we'll speak about the why, when and how to use DBT, the dose that's attached to it, and the synthesized 2D concept, the display, transmission and storage of images, and then about radiologist training and reading times, and referrer and patient education. So DBT's really got very widespread use now. It was approved by the FDA back in 2000, full field digital mammography was, and then DBT came along about a decade later. And it took a few years before the concept of synthesized 2D images came in. And by 2020, so about five years ago, there were 4 FDA-approved vendors for DBT. And back in 2015, it was already getting a lot of excitement. There was, as that Aunt Minnie quote says, it was tomo everywhere at the meeting, right? So a lot of interest. And according to the MQSA, about 71% of radiology facilities, breast imaging facilities in the USA, have actual DBT capability as of 2020. But it's really, in recent years, got widespread adoption due to the fact that there's evidence that it can improve cancer detection and increase false positives, which are the two challenges of reading a mammogram. So what limits digital breast tomosynthesis, or what limits mammography, is mammographic breast density. And mammographic breast density, as you would know, is the ratio or the comparative amount of fibroglandular tissue, which is the white tissue in the breast, to the black components, the fat in the breast. And density, that is a greater proportion of fibroglandular tissue, is of course more common in higher in young premenopausal women when, of course, they need that glandular tissue for breastfeeding. But as you get older, and particularly postmenopausally, the amount of fibroglandular tissue in the breast tends to decrease. And it will change, of course, with different physiological states. So things like lactation will make a difference, or if you're on various drugs like tamoxifen would decrease the amount of fibroglandular tissue in the breast. But what we can say is that there's a really wide distribution of density across any age group, and that's what that bar chart shows. If you look at the pale purple colour, which is the first bar in each column, you'll see that it actually represents the fatty component of the breast, and it increases over the age groups. So as we go from the under 40s here, it's very low, and it increases gradually until we get to the over 80s when it's quite high. And alternatively, if we look at this bright pink or bar, you'll see that it is the high density component, and it actually gets lower over time. But it's not uniform. It's not to say that any woman in her 40s is likely to be high density or low density. You can see that, in fact, there's quite a distribution in every single age group. And about 40% of women in Western societies, which is probably not true necessarily of all the countries where you come from, but certainly in the States and in Australia, about 40% of women who are older than 40 and are in the screening age group would have dense breasts. It may well be higher, I think, in Asia. Your breast density is actually largely genetically determined, and this is something we know from twin studies where identical twins have very similar breast densities, and fraternal twins have similar densities, but not quite the same as identical twins. Now, we spend a lot of time talking about density because it's associated with two significant risks, and I'm going to mention those in a moment. But one thing you can see on this classification, which is the BI-RADS classification of A, B, C, D, the A being fatty and the D being white or dense, is that it actually gets more difficult across this spectrum to see an abnormality within the breast tissue. So if we go to the next slide, we can see that there was a meta-analysis quite some time ago now, back in 2006, so 20 years ago, which showed that all the studies up till that point showed that there was an increased risk of developing breast cancer if you had a dense breast. And the relative risk of comparing low density versus high density breasts showed that a high density breast had about 4.6 times the risk of developing a breast cancer. So one specific important study was this one, where they looked at a screening program, and what they showed was that the odds ratio was adjusted for all the things we know might affect your risk of cancer, and then they were able to show that even after adjusting for those factors, density led to an increased risk of breast cancer when you compared the very dense with the very fatty, and the overall it was about 5 times, so that's the same as the meta-analysis. If you actually looked at cancers detected at screening, there was a greater chance of cancers being found in dense breasts, right? Because there are more cancers there. But there was a much greater chance that the cancer wasn't found at the screening, that it was found in the interval, and this is about 18 times in the first 12 months after screening, or 6 times in the second 12 months after screening. If you'd had a normal screen, you are very much more likely to develop a breast cancer in the interval if you had a dense breast. So 2 main risks, cancer development about 5 times, and missing cancer on a mammogram somewhere between 6 and 18 times that of a fatty breast. So you could see from these 3 cases that, this ill-defined density, non-specific density, which is in fact a cancer, is relatively easy to see in this breast. Doesn't have very specific features, but just because it's there, empty area, it's pretty easy to see. If we go to this moderately dense breast, we can see that in fact we can find cancers in these breasts without too much trouble if they're in the right place. And this is a little cancer up here, in an area in the prepectoral space where we shouldn't have densities. And so in fact that small density, which is a cancer, is relatively easy to see because it's in a strange place. But were it to be in this upper breast here, we would have a lot of trouble seeing it. Just as we can't see the cancer, which we now know is in this breast. It's just too dense. So the principle of tomosynthesis is basically to try and get a better mammogram. Right? We've got this density that's obscuring our ability or limiting our ability to find cancers. And we can address that by the idea of moving the tube and acquiring multiple projections. So this is the normal projection, this central one here. The X-ray beam comes straight down through the breast and we get whatever's in the way superimposed upon itself, like so the triangle or the star and the circle are superimposed. But if we come from different angles, we can move those structures apart. And that's the basic principle illustrated in these diagrams. We have the cancer, which is purple, and the blue fibroglandular tissue. We take our regular mammogram. We end up with an image like this, where the blue is seen obscuring because it's lying on top of the purple, and we can't separate those structures out. And it may be that those multiple blue dots together, in fact, also make us think that there might be something there, when in fact there isn't something there because they're lying on top of one another. So when we do the slices here, what we're able to do is slice through the breast after we've taken these angled images and reconstructed them in a 3D format, and eventually we'll come to a slice where we can see the changes that will help us recognise that there's a cancer present. And that's just illustrated in these 2 examples. We have a non-specific density here, but we can see when we actually go through the appropriate tomo slice that this is a lesion that is irregular in shape with some spiculations and disrupting the normal tissue, something that's very hard to appreciate on the regular 2D image. And likewise, in this case, we can pull out a very obvious spiculated mass at the top here, small spiculated mass lying within this very dense tissue. So the idea of the tomosynthesis technology is common to all manufacturers, but they do vary the factors or the system parameters, design parameters, depending on the manufacturer. So for example, the scan angle, how wide an angle you use, it differs quite a lot from manufacturer to manufacturer, and it changes various outcomes. So it changes the amount of overlap or the sharpness of the separation of structures and the field of view. The number of projections you take also has an effect. The scan time and the tube motion, whether or not the tube stops or moves, etc., smoothly through the whole process, these will affect things like patient movement. The reconstruction algorithms make a big difference to what the image looks like, and the number of reconstruction slices will make a difference to the image quality. So we're not going to go into the different manufacturers in this talk, but certainly the vendors have unique approaches to DBT, and it's not always obvious, and certainly not to the users such as myself. It's not always obvious what the effect is going to be on clinical outcome, but you have to have a look at the final images and learn to make the most really of your own particular DBT system. So let's come to another aspect of using DBT, and that is selecting the patients that we might want to do the studies for. Right? So Our main aim is to maximise sensitivity, that is to find the cancers, and to minimise the specificity in a sense, or improve the specificity so that we don't call back too many people or do further assessment of too many people who don't have cancer. We want to optimise our resources and the workflow. We want to make sure we triage patients the correct way so that we have a nice smooth workflow. We want to optimise our interpretation of the images, and this comes with having had adequate training and also how we go through the image study. Our concerns are who's going to benefit from this, right? Who benefits? What are we going to do with all these images that we've got? What's the dose that we're using? What are the costs of implementing this procedure? And what are the risks which we might term overdiagnosis? And we'll talk about those in more detail. So the question might be, which patients will we do this study on? Is it going to be everybody? Or will it be some selected screening patients that we do this study on, DBT? Should we be doing it at the time we do the screening, or should we be doing it at the time that we do the assessment of screen-detected abnormalities? What about diagnostic patients? Is it suitable for all of them or just selected diagnostic patients? And when we do it, are we going to do bilateral 2-view, MLO and CC of both breasts with DBT, or should we do something less? And so all of these questions have been addressed in various studies, which we'll discuss. So who benefits? Are we going to do it just for patients who've got increased risk, such as high mammographic density, the BI-RADS C and D, or are we going to do it for increased risk populations, such as people who've got a family history, or people who've previously had the disease, or people who've had, let's say, been on hormone replacement therapy for a considerable period of time? Or are we just going to say we'll do it for all patients, regardless of their age, density, or risk? And these are all questions we need to answer before we embark upon using DBT. And of course, it's going to be affected by our resourcing. Do we have DBT on all the pieces of equipment that we're using for our mammography, for example? How do we triage our patients through our mammography units? And what's the workflow like? So the first big studies that came out quite a long time ago. They came out in 2013, and they were both screening studies that looked at DBT and compared it to DBT, looked at digital mammography, I should say, and compared it to digital mammography with DBT. And both of these studies, the Oslo study and the Storm study, showed that you could increase cancer detection quite significantly. In this study by 27% and this study by 51%. So big increases in cancer detection and a decrease, a lesser number of false positives by somewhere around 15 or 17%. So these are two really good outcomes. You can find more cancers and assess fewer women. And which group benefited in these studies? Well, they were able to show, no matter what the density, BI-RADS A, B, C, D, or 1, 2, 3, 4, as it used to be at that stage, each group benefited. So the 2D is the white, the pink is the 2D plus 3D, and you found more cancers in the pink groups in every age group, in every density, and in every age group and density. So it was pretty reassuring that you actually can benefit everybody by using DBT, but obviously the greatest number of increasing cancer cases is in the two middle groups, the BI-RADS 2 and 3, but they are the commonest groups. So some studies looked at DBT at the time that you were assessing women. So we've already found a non-calcified abnormality on the mammogram, which we want to evaluate, and we're looking at how does DBT compare to the normal workup views that you would do, compression views. And so in this particular American study, they showed that the patients were examined with both DBT and supplemental views if they had asymmetries or distortions. that had been found either by clinical mammogram or ultrasound or MRI. And they significantly improved their accuracy when they used DBT compared with supplemental views. Same cancer detection, fewer false positives, better cancer categorisation as being definitely cancer. So the question was, can DBT replace mammographic workup? And the answer is yes for soft tissue lesions. It does work very effectively for soft tissue. You still, of course, need to do magnification views for calcifications. And another study here looked at screening, which was a UK study, and basically these were women that were called back from screening program to have further assessment because of a screen-detected abnormality, and they were able to show that while it didn't change the sensitivity because they weren't looking for extra cancers so much as it improved the specificity, that in fact they were able to decrease the number of cases that they needed to worry about. So if we look at a meta-analysis that was done at the time, or a review that was done at the time back in 2013, they were able to say that all these studies to that point had shown that the addition of DBT to a digital mammography increased the accuracy of mammography. And the accuracy was represented by an improved cancer detection or a decreased false positive recalls, or both. And then there was a study that looked at whether we really needed to be doing it for two views. And this was the Malmo tomosynthesis trial in Sweden. And basically what they did was they looked at MLO DBT only versus digital mammography. So they just did a single view with tomo. And they were able to show that DBT only improved the cancer detection across all different density breasts. It increased the recall rate in their situation from 2.6% to 3.8%. It actually took longer to read, approximately 2 times as long to read the digital mammogram, the DBT, as it did to read the digital mammogram. And they, however, had reduced the radiation dose by doing one view DBT. It was about 70% of a 2-view digital mammogram. So what this study, the point of this study really was to show that in fact you could get good results by just doing a single view DBT study. And one other thing to point out is the fact that while their recall rate went up, which was different from the other studies we've talked about, they had a very low starting point. This is a very low recall rate for screening, 2.6%, and this is a very acceptable 3.8%, even after they've increased it from the 2.6. So obviously they've raised one issue there by talking about the dose, and if you do a 2D and a 3D, particularly if you do them at the same time, you get the best image interpretation. And it's the easiest workflow because you're doing everything just at the same time. But if you acquire 2D and 3D at the same time, well then basically you're doubling the dose. So the question was asked, is a 2D image really necessary? Do we have to do 2D? And I think the answer is clearly yes, because we're all familiar with 2D. It gives you an overview. It allows you to compare one side to the other side very easily. It allows you to compare with priors very easily, and it helps you get a feeling for the distribution of findings that you see on the mammogram. So I think everybody agrees that a 2D image is necessary. So that brought us to the issue of the dose. What was the dose if we were doing 2D and 3D? And it varies a lot with the different manufacturers. So basically what we can say is there's an increase in dose, but how much of an increase varies depending on which system you're using. So it led to the idea of a synthesized mammogram, right? A synthesized 2D image, which if we were to use a synthesized 2D image, we could decrease the extra dose by 45%. So combined 2D and 3D more or less doubles the dose of doing just a 2D alone. but it's still a relatively low dose and still well within guidelines. But if we use the synthesised 2D mammogram, we'll be able to reduce the dose and still get the same outcome. When we say it's still the same outcome, there has been a lot of variation in the image quality of synthesised 2Ds from the different manufacturers, but they've all really improved a lot in recent years. So I think pretty well all synthesised 2D images nowadays are very good quality. So synthesised 2D is in fact just a maximum intensity projection image, a MIP, created by collapsing all the DBT slices into a single image. And as I said, the quality has varied by vendor, but they're all pretty good now. So you just really basically get the tomo slice. If you've got, let's say, 25 tomo slices in a thinnish breast, and they're all put together, you'll end up with an image that's synthesized. And they're often quite hard to tell from a conventional 2D image. Do they work? Well, the Oslo study looked at this. It looked at the impact of a reconstructed 2D study, 2D image, and what it showed was that there was no difference in the cancer detection between a synthesized 2D and a acquired 2D, and there was no significant difference in the false positive rates if you compared using a synthesized 2D or an acquired 2D. So they were equivalent. The same thing was actually shown in the Tommy trial, where in the UK they'd recalled women to assessment and they compared the acquired 2D with the synthesized 2D, and they basically got the same results. So it clearly works if you've got a good quality synthesized image. What about the size of the images? Unfortunately, the size of the images is getting worse, really. They're getting bigger and bigger. So DBT images are typically large, and we generally speaking compress them with something like a JPEG 2000 lossless technique, because that makes it faster to transmit and to load the images, and it takes up less space with your archiving. But when you compare the size of 4 images, right, acquired on 2D, you've only got 88 megabytes, let's say, of information. And if you look at the Tomo, you've got 1.5 gigabytes. It's huge difference in size, right? And it makes a big difference to your file storage and costs. Of course, the file sizes, as I say, are getting bigger rather than smaller necessarily. And there are, lots of issues around that, particularly around the transmission time and having sufficient bandwidth for efficient display time. So there are IAG standards for the images, and it's important that the images carry all the DICOM information that's appropriate and that's necessary for processing, storage, display, etc. And that all synthesized 2D images are labelled as such, so that we know what's a synthesized image and what's not. And this standard approach, of course, allows us to integrate viewing with images with all different vendor workstations, so it makes things vendor neutral. Now, we can talk a little bit about the display, and it's a very important thing in terms of your workflow, isn't it? How you display the images, and I'll just show you some some options for your display. So these are just at the side here, some display protocols. You could go down from 4 images to 2 MLOs to one side MLO, the other side MLO to the CCs. And if you've got priors, you can increase this by adding in the prior before you add in the 3D comparison. So you could start off, for example, with an overview like this, your currents and your priors, and then you could look at the 2 MLO views, the 2 CC views, then you could start to look at the MLOs with their priors, and then you could look at the MLOs with the DBT. It's quite time consuming if you're actually going to go through these studies thoroughly and carefully, it does take time. So there's a learning curve attached to it as well. And as you know, the FDA has a requirement for radiologists in the States to actually spend at least 8 hours of training when they take up a new imaging modality such as tomosynthesis. It's important to not only get the general principles right, but also to try and understand the specific equipment that you're working with, because there are variations, as we discussed earlier. So the interpretation time has been shown, of course, to improve with time. So when you first start to read, it maybe takes you 2 times. So in the Oslo study, it increased from 45 seconds to read a mammogram to 91 seconds to read a mammogram and tomosynthesis together. But they were able to decrease the time that it takes over a period of time. So I guess we know that you get quicker with more practice and more skill, but it is important to realise that it is going to take you a little longer to interpret DBT images compared to what you're used to with 2D images. We can reduce the time a little bit by the idea of slices or slabs. So slices being the individual 1 millimetre slices as we go through the breast, and the slabs being where you would put together a series of slices, let's say 5 or so, and maybe they overlap. So you might have, let's say, slices 1 to 5, and then maybe 4 to 9, etc., and then maybe 8 to 12, whatever it might be. And this way you can look at them in blocks, and that does reduce the reading time without compromising interpretation, and we can look at that later. The other thing just to highlight is that it's important that not only you learn about DBT, but that the doctors who are referring to you and the patients who are actually learn a little bit about DBT too. So there have been studies done to look at, how patients appreciate the difference, or do they think there's a significant difference in the 2 studies? Does the time that it takes for a tomo worry them or not? Generally speaking, there is no particular difference. And this is just an example of some material that we prepared once some years back to just inform patients about the difference in the studies. So while DBT typically leads to an increased sensitivity and specificity across all ages and all densities, and it does make you feel more confident about what you're dealing with, and it can replace non-magnified work for soft tissue lesions, you have to realise that it's not a perfect tool. So DBT is by no means going to show you every cancer, because you still have cancers that are not got enough fat around them to actually show you margins of the lesion, no matter whether you do TBT or not. Right? And sometimes that just depends on the type of lesion it is as well. Things that are less defined or less spiculated are less likely to show up on tomo compared to other lesions. The spiculated lesions are definitely the lesions that are most easily seen on tomo. So that leaves us with a few questions of why isn't it more widespread, why doesn't it have more widespread use? And I guess it comes to various questions around cost effectiveness. So the first is the greater cost of interpretation time, and the most important thing here would be that there's been no significant difference in the interval cancer rates or advanced cancer rates in the studies that have used DBT. So this is a burning question in most screening programs around the world. Why hasn't it decreased the interval cancer rates? So another factor that limits its use has been the fact that it does increase cancer detection, but at a lesser rate than using ultrasound. That's not to say that you can't do both. You could do tomosynthesis and ultrasound, and most practices do that. But you have to realise that ultrasound will add more cancers to your detection rate than tomosynthesis alone, and certainly a lot less than contrast studies such as contrast mammography and MRI. And then that brings us to the point that if you're finding more cancers and you're not decreasing the interval cancer rate, are the cancers you're finding what we call overdiagnosis cancers? Are they meaningful cancers, or are they just cancers that wouldn't have been a problem for the woman in her lifetime? And these are all the controversies that really go with using tomosynthesis in screening. So I'll finish up here by just mentioning that why we use it, because we have some limitations with standard mammography. For whom are we going to use it? We're probably going to really say that we can use it for most patients, really. It's useful for everybody. The limitations might be on our own availability to do it. How do we use it? Well, generally speaking, we're going to use the synthesize in place of an acquired 2D. We need to learn how to use the display and all the issues around the actual dose transmission and storage. We must make sure that we've had our own training and that we've educated our referrers and patients, and to recognise that there are some limitations of the technique, no matter how well we do it. And what those are around really, what are the benefits to the patient, what are the patient outcomes, and how cost effective is it to use this technique. So there might be lots of issues in that talk. I hope you've found it interesting, and we might look at some of the issues that we've raised when we go through the case material. So we have 10 cases to go through now, and I'll stop sharing this particular presentation. I might just actually end the show, and I might reduce this. And now hopefully I'm sharing the platform here. I hope I am.
Yes, we can see. Professor.
Good, okay. Just go into this. So we'll start off, I'm actually on case 10 here, so I better go back to case number 1. So Tonya showed you before some of the cases, or how to use the platform, I should say. And along the side here we've got our series, so if we want to we can pull up any cases. We don't have the time really to go in full detail of how you would examine each of these cases. Unfortunately, we don't have the time to do each one in detail, but let's just have a look at zooming up. Let's say I might put this here as 2 cases. I might display it this way as 2 images, and we'll just compare these 2. We'll sync them and we'll zoom them up, and we'll try and analyse whether we think there's anything here that is different on the 2 sides. And this is a fairly subtle case, I must say. In fact, quite a few of these cases are quite subtle. So if we compare, when we zoom up, we look from side to side and look to see whether there are any differences and any calcifications that we might see which we didn't see or weren't as obvious on the non-zoomed images. And clearly down here, this patient has got these calcifications that our eye is drawn to. And then when we're looking at these in more detail, we can see that there's a rather non-specific density here adjacent to these calcifications. This area here compared to the other side, where we've got a more normal sort of space between, fatty spaces between the tissues. So this is quite an obvious asymmetric density. And maybe we'll go to the, just back to the 4 images here. And if we have a look here, we can see it here. Can we see it on the other image? On the other can, if we can see that it's lying in relationship to these calcs, the calcs are here, and there's a bit of a non-specific density here. So maybe that's what we're looking at. Now, if we look at the tomo on the CCs, what we can see, and these are slabs that we've got up at the moment, we can actually scroll through the slab. I'll take away the sync. We can scroll through the slab, and we can see that as we go through the slab, it becomes obvious that there is a bit of an architectural distortion attached to this density. So if you go through, we come to the area where it looks a bit distorted. Huh? Okay. What does that mean? We'll go on to the next view, this view, and we'll have a look here. And maybe in this particular case, I'll go and look at it in the individual slices, the planes. So we'll just have to wait while it loads up the top here. But the individual slices, or the planes, actually give you a greater detail. The slabs are where we've put 4 or 5 slices together. So let's have a look here at this one. And I might, to make it a little bit more clear, I might zoom this particular area up for you. And then we'll go through the slices one by one. And as we move through, I think you can see that all of a sudden we have an area that's ill-defined and spiculated. Can you see the spicules coming off this? So this non-specific density here has become far more obvious as being a malignancy. It has all irregular shape, ill-defined margins with spiculations, right? So this is a case where there's an invasive cancer here. And I won't go through the normal side. This is in fact a normal side, but when you're going through yourselves, you can go through in more detail. So this is a case where we've got an ill-defined density, rather non-specific on the 2D images, and quite definitely malignant when we go to the 3D images. So I'll go to the next case. Now, we were going to try some polling, so maybe we might try just the initial poll question at this stage, I think, to let you see how the poll works. So will we do that? Hi, hun? Yep. Okay, so this is a poll question here, and the idea is that you can answer the poll question just to get a little bit more involved in what's going on. Have you used a poll before? So we can stop whenever you'd like, whatever you'd like to do. We've got 20 of the 30 have already participated. So I guess what you can see here is that 2/3 at least, or 3/4 of people, 3/4, have actually used polling before. So we'll use that on our next case. We'll move on to the next case. Well, in fact, maybe we won't use polling on this case, but anyhow, I'll sync this a bit just to make sure that the images are synced. Right, now this is quite a difficult case also. If you're trying to look for the abnormality on the 2D, I think you would struggle. I'm just wondering, yeah. Okay, just at a glance, I think we could try at this stage, or maybe I'm making it a bit too early. Let me just make it here like this. I'll actually show you the abnormal side, right? So the abnormal side, in fact, is the left side. So if I pull over the CC and the MLO and I zoom them up a bit, my question to you is, with the poll question now, we can bring it up. The poll question for case 2. Looking at these images, this is the question. Would you recall this case based on the 2D images alone? Okay, so it looks like people are tending to say yes, but I'd have to say I think this is a very difficult case, right? So I'll close that, and I think you'd have a lot of trouble seeing where the abnormality was. Unfortunately, I can't go through all the detail with you here, but what we'll do is just have a look now at the CC images, right? So here are the CC images. Okay, we've got a bit of a density at the back here, but it doesn't look too bad. And in fact, when we scroll through this, we can see it's a pretty well-defined image, and she's got some other lesion, and she's got some other well-defined lesions too. So this all looks fairly benign. So we'll come back to this side, and I'll scroll slowly through this particular slab images, and I'll stop here. Can you see the abnormality? Huh? So here's the abnormality, isn't it? As you come along, the contour is broken by an area that we can see is clearly spiculated. No? Really a little spiculated lesion in this area. Very difficult to appreciate as a spiculated lesion on the 2D. You can see the area, of course. In retrospect, it's quite obvious where it is, but whether you would pick it up as being spiculated as you can here. And we can see the same thing if we were to go to the planes rather than the slabs on this. And we can have a look at that in a second as it loads up here. And you'll see that, in fact, there's very little difference really, even though there's a lot more detail in the slices. The individual planes, there's not a lot of difference in fact what you can actually perceive. So as we move through this, here we do have greater detail, but when we actually come to the lesion itself, it's probably not seen with any greater ease, even though we've done individual slices as opposed to slabs. Okay. So this again is a small invasive carcinoma. I'll show you I think we haven't looked at this image, so we'll just, we'll look at this one here. Might go back to the slabs. So all of a sudden, the area is obvious, isn't it? Here's the cancer, little spiculated margins, small central density in here, very hard to perceive as an abnormality here on the on this 2D image, right? I just feel it'd be very hard to identify without quite a significant careful scanning, whereas it's very easy to see here. Okay, this is another invasive carcinoma. We'll move on to the next case. Not sure how I'm going for time, but probably not terribly well. Or maybe I'm going okay. All right, so this case here, this is case 3. So just out of interest, how would you classify we'll ask the poll question, how would you classify the density of this case? Is it low or high mammographic density? So generally speaking, low is an AB and high is a CD. Yeah, we've got a pretty unanimous sort of approach to this so far. So I think the poll's showing us that most people think this is high density. And I guess that I put it in because it does illustrate one of the issues of density, in that sometimes the density is non-uniform, isn't it? The density distribution is non-uniform. This is, I think, a high-density breast, probably going to be classified as a C rather than a D, because around the breast cone, you've got quite a lot of fat, this grey fat. There's quite a lot in here. If you were doing a Volpara inside the breast cone, anyhow, this is a high-density breast and should make it easy to see things on the tomo slices. So maybe we'll have a look at these particular slices here. So the slabs on this side, let's have a little look. And what it does illustrate is how easy it is to see small benign lesions like this lymph node, right? So there's a lymph node here, and it's very, very sharply marginated on the slabs or on the individual slices as well. Very easy to see. look at the other one. I'll have a look at this particular view again. And apart from seeing that normal lymph node with the hilum nicely shown, etc., we're not seeing anything that would worry us. And I won't go through all the slices because this is in fact a normal case, but it does allow you to move through the tissue planes quite easily, and certainly at the level of the nipple you're getting a nice sharp demarcation of the various tissue structures. So easy to see that this is nice normal tissue. So we'll move on to the next case, case 4. So case 4 is actually a patient who's had some treatment. I'll actually sync this up so that you can see the difference in the two sides. So this one, the left breast, is reduced in volume because she's had surgery, and it's distorted. We've got this distortion up the top here, which we can see is most likely the distortion caused by surgery. But let's have a look at the detail, because these breasts can be actually quite difficult to analyse. Obviously, you would have the priors often available to you, but even so, they're still very difficult to see whether there's a significant change or not occurring in the breast tissue. All right, let's go on to the tomo. Okay, now in this particular case, if we scroll through, we can see quite easily the scar. Tomo is great for scars, right? And it shows you very easily where the scar is. But what it also highlights, and I think brings to your attention, is that while this pattern out here might be normal, for example, a normal soft curvy sort of pattern, we have a strange connection out here to an irregular shaped mass. Right? It's visible, clearly visible on the original 2D image, right? But it's just so much more obvious that it's suspicious when you come to this particular tomo slice. So we're seeing a couple of features that make it look suspicious. One is it's very irregular, and it's sort of connected to the periphery of the scar here. The other thing that you can see quite clearly, which is much more difficult to appreciate on the original 2D images, is the calcifications that are within the tracking within it. Right? And these calcifications raise a suspicion for ductal carcinoma in situ, and this component, the ill-defined mass lesion, raises the suspicion of invasive carcinoma. Now, I want to just highlight the other side. So were we to scroll through the other side, I guess all this pattern looks pretty normal. Now, she has an area here where there's quite clearly disruption of the normal pattern, but it looks like it probably is benign fibrocystic type change. It's rather nodular and a little bit contracted, and it's got some calcs. But what is a bit different, and what does again come into play much more clearly on this particular tomographic slice, is this change down here. And if we are to zoom this down here, and pan it out a little bit, you can see it's got some of the features of this that are the same as the other side. It's an irregular, ill-defined, non-specific density with the hint of a few fine calcifications within it. So unfortunately for this lady, she had bilateral disease. And the bilateral disease or recurrent new cancers are seen quite easily on these slab images, right? All right, that was case 4. Let's go on to case 5. So case 5 has a finding that's fairly straightforward, I think. When you just look at it even at this level of magnification or zooming, you can see that there's an asymmetric density. So we're really interested to analyse this asymmetric density in more detail. So let's do that. Let's move on to a Tomo slice, and let's see what it looks like on Tomo. Now, as we move through the slices here, we start to see the margins so much more clearly. It's hard to compare, isn't it? It's hard to believe that we're seeing quite the same thing when you compare that and you compare that. The level of detail about the margins is so much greater on the DBT. Huh? And what we can see is it's what we would call a macrolobulated lesion. It's got lobulations, but the lobulations are large, generous sort of lobulations. Huh? On this other side, we don't have any concerning abnormality. Let's move to the other view. And we could look at this one if we want to in more detail by clicking over to the planes. And I might zoom this up a bit. And we'll have a look at the slice as we move through it. So what you can see on the other view as well, in this view, is that it's got very well sharply demarcated margins. Right? They are lobulated, but they're extremely sharply marginated. And it's got a spunny shape with a bit of a nodule, lobulation poking up the top, which you can't really appreciate on the original 2D image. So we did have a poll question here, and the poll question on this, which is case 5 poll question, is are benign lesions typically greater in density than the normal adjacent tissues? Yes or no? So we're talking about whether you think benign lesions are normally greater than the tissue around them in density. So what we can see here is there's a bit of a mixed approach to this question. Maybe the yes is winning by a tiny, tiny fraction. No, the no's are winning. Well, basically what it tells us is that, it's not a terribly reliable sign, is it? Density is not it used to be a more reliable sign when you were actually looking at 2D mammography, or I should say film screen mammography, before the days of digital. But because of the range of greys that digital can give us, we've ended up with a pretty much split 50-50. The range that digital can give us in terms of greys, it's harder to appreciate the density difference. But essentially, most soft tissue lesions that are benign don't actually have a greater density than the surrounding tissues, whereas malignant lesions tend to be denser because the tissue or the cellular content is more concentrated in spatially. Anything that looks much more or less, given it's a mass, it looks much the same as the surrounding tissue. And it has very benign features, and this is in fact a known fibroadenoma for this patient. Okay, we'll go on to the next case. How are we going? Yeah, nearly there. Okay, so this particular case again is relatively subtle. If we look at the two, let's look at the 2D images. I'll just sync them, and we'll look at these images. There is a difference. Let's look at these two. If we're comparing side by side, we don't have to go very far to see that we have an asymmetry. Right? Right out the very lateral aspect of the CC views, we can see that there's an asymmetric density here. But it's what we would term a non-specific density. It's just an ill-defined asymmetry. Not terribly different from, say, this little ill-defined asymmetry. But it's focal and it appears to have a calcinate. If we then do a similar comparison of the two sides here on the MLO views, it's actually quite subtle to see the difference. Okay, I'm going to take you to the Tomo to make it easier to find. So if we go to the Tomo here, what we can see when we actually look at that density in more detail, particularly when we get to the appropriate level on the tomo slices, is that clearly this is a spiculated mass, right? Because these little streaky bits come off as clearly spiculated. And we can also see that the calcifications clearly lie within the centre of that mass. This is a little malignancy, and the calcifications obviously represent some DCIS within the invasive tumour. Let's have a look at the other projection. So this is, we might swap over to planes here, because this is a more difficult projection, isn't it? So let's zoom this image up and I'll zoom this image up in a second when it's fully loaded. I think I'm running out of time, aren't I? Is that correct?
Yeah, I think that's okay. Still, we have 5 more minutes.
Okay, good. Well, we won't finish all the cases, but I'll show you a little bit more this case. So we'll just zoom this one up a bit and it over a bit. Okay, because we're interested in where this little asymmetric density that we saw on the other view, and I can bring that over just out of interest here. We saw it up here. So let's have a little bit of a look through on the tomo. And as we come through on this tomo, I'm just getting a bit stuck, this tomo. Why is it a bit stuck? It was working well before, but it's got a bit stuck, hasn't it? Let me see if I can maybe get it unstuck here. No, it's stuck. Oh, let me try the slab. See if the slab will work. Yeah, the slab's working. I don't know why I got a little bit stuck there, but anyhow it did. We're going to have a look at it here. We suddenly come into what is an obvious mass. So that's actually hard to see, right? When you actually come into this, it's actually, until you get to the actual slice, this is a hard tumour to find. It's a little irregular, ill spiculated, finely spiculated tumour. So not an easy cancer to find. So I might take us back to the 4 pictures. I think I've got the next one here. Just sync these a bit. So coming back, where is it? The little tumour is in here on the tomo and on here on the tomo. But coming back to the 2D, the original 2Ds, I think it would have been a very hard cancer to diagnose. So given the time, I won't take you through the last few cases. I'll leave those for you to do on your own. Obviously, you have, I think, a month to spend to go through these cases, and you'll get them quite a lot of benefit if you go through them in slowly and, concentrate on the various findings. They're all interesting cases, and they all tell you something about the value of DBT. So I hope you've enjoyed them, and we can answer a question or two if that's okay. Would you like to that I answer any questions at this stage?
You can leave a question in the Q&A box.
I haven't seen any myself. Are there any there that I should?
I also didn't see any questions so far.
Okay. Well, look, if people have got questions at a later time, they can always send them and I can always answer them later. Even over the next month while they go over the case material, they might come up with a question, right? Something they're interested to know about. And I'm happy. I'll stop sharing then. I'll stop sharing this case. But as I say, I'm perfectly happy to answer any questions at any stage. Huh?
Thank you. Thank you so much, Professor Rikan. Maybe we will take just few quick questions. I can see one question just came up.
Okay.
Do you typically do ultrasound for screening cases in virus density B?
Well, it depends on the setting. So we in Australia have both a national screening program, which is free for women to attend, and they're targeting women aged 50 to 74. So those women can come in and have a free screening mammogram, and the screening process is mammography only. So regardless of the density, they only get a 2D mammogram. Now there's another option in Australia, which is the private sector screening, and that is generally speaking for women who are at increased risk because of their family history or some other factor, and or for diagnostic patients with symptoms or signs. So in that environment of screening women at slightly increased risk, we always tomo and ultrasound patients who have high-density breasts. I would say that's pretty well across the board. Most private practices in Australia would do tomography, and they would also do ultrasound for breasts that are CD. The thing that's increasing a lot in Australia, in fact, is rather than doing mammography and ultrasound for density, we're doing contrast mammography for density. So that is an increasing trend. But certainly if we're not doing contrast mammography and we're just doing straight non-contrast mammography, be it with or without DBT, we would add ultrasound when in the case of high density.
Thank you. Is there any other questions? We will just take one more if you have. Okay, I think with that, if no more questions, as we've reached the end of our scheduled time, and just we would like to summarize. Thank you so much again, Professor Ricard. It's been a very valuable session and very interactive session with everyone with polling questions. We appreciate your time. And to everyone who joined us today, thank you for your active participation. There is just a final reminder before we close. You will continue to have access to this detected activity module for 1 month after today's webinar. So feel free to revisit the cases and continue learning at your own pace. And once you've completed the module and submitted the simple questionnaire, you will find the certificate of completion section at bottom left of the page. So click on certificate of completion or choose the send via email option to get the certificate. We hope you found today's session enriching and very practical. Yeah, so we end the webinar here. Have a great evening, and we look forward to seeing you again at future educational events. Thank you, everyone.
Thank you.